I'd like to thank everyone for attending today's MBI webinar. It should be a really interesting talk on both asthma and MRI. We had Claire here doing a lot of scanning. I'd like to wish to acknowledge the people of the Kulin Nations on whose land Monash University is positioned. I pay my respects to their elders past and present. A few housekeeping rules. If you would like to ask a question, please use the Q&A feature. And these will be answered at the end of the speaker's presentation. The chat section has been disabled, so questions have to be written into the Q&A section. It just makes it a lot easier down the track. As for today's speaker, it's a real pleasure to introduce Claire O'Sullivan. Claire worked as a clinical scientist for the National Health Service in the UK. She then moved to Australia to undertake a PhD, and the work she'll present today is from her recent PhD studies with Professor Bruce Thompson at the Alfred Hospital. Her work investigates airway physiology and asthma using traditional physiological tests coupled with new innovative MRI techniques. So really looking forward to your presentation, Claire, and let's kick this off.
Great, thank you, Michael. So yeah, as Michael said, I'm Claire, and I'm presenting today the work I've been doing as part of my PhD, which focuses around the peripheral airways in asthma, their significance, assessment and targeted treatment. And it's quite a collaboration. So my funding is through Monash University, and I've been using MBI as my research space. Other than that, I'm located at the Alfred Hospital, and that's where I've done my patient recruitment. My actual PhD is enrolled at home at Newcastle University. So I thought I'd just start and do a bit of an introduction about asthma. So asthma is a multifactorial disease, and it's still prevalent, affecting 300 million people worldwide. That was reported in 2019, so it's still a big problem. I think it's accepted now that asthma actually is like an umbrella term, and perhaps that's been a little bit limiting in the progress we've made in the management of asthma up till now. So it's a very heterogeneous disease. Classically, it's characterized by reversible airflow obstruction, which is secondary to airway inflammation, and the presenting symptoms secondary to that include wheeze, shortness of breath, chest tightness and cough. And on the right here, I've got an example of kind of like a basic test of respiratory function that we routinely do. It's like the bread and butter of respiratory function testing called spirometry, where we measure flow and volume over a maximal exhalation. And what we would classically see in asthma is at baseline, so without any bronchodilator medication, reduced flow there in green. And that's due to the airway obstruction, and this responds to bronchodilator. So you can see the post bronchodilator trace there in red with greater flow. So asthma management has come a long way recently, and inhaled therapies form the mainstay of asthma treatment. Those that continue to be poorly controlled or refractory or have severe asthma despite inhaled therapies might proceed to be treated with anti-IgE or biologic therapies that act on immunological pathways. But despite this, there are still patients that remain poorly controlled. And in recent years, the European Respiratory Society has communicated its ambition to achieve asthma remission. So we still have a long way to go. So just thought I'd talk through some other respiratory function assessments that we can use when we're assessing airways, maybe in asthma. So spirometry is the traditional test that I've just talked you through. It can identify obstruction, and it's the test that is used mainly in the clinical space when we're managing asthma. But it is insensitive to the small airways. So there are other tests that we can do, such as inner gas washouts. There are various gases you can use. The example I have here is a nitrogen gas washout example. So nitrogen makes up most of the composition of gas that we breathe, so we have it resident in our lungs. And what we do in this test is get the subject to breathe 100% oxygen and then wash out the nitrogen, from their lungs. And it's the rate of this washout and also the shape of the expired nitrogen concentrations over the duration of this test that we use to calculate ventilation heterogeneity. And we can be a bit more specific with the regions with this test. So we get a calculated ventilation heterogeneity measure for the asthma or peripheral region, and also for the conductive region. Another test that we do is called oscillometry. So oscillometry literally uses like a loudspeaker, and those sound waves or oscillations of various frequencies are superimposed onto tidal breathing. And we look at changes in amplitude and also flow changes to work out the resistance of the respiratory system as a whole, and also the reactance, which is a marker of respiratory system stiffness. So we're looking at more sensitive tests that can, is everything okay? I can't see anything in the chat. Okay.
No, it's good.
Okay. So yeah, just to introduce the small versus large airway debate. This has been going on for some time now, particularly as these more sensitive tests have been emerging. And there's been more of a focus on measuring what's going on in the small airways in terms of airway mechanics or ventilation heterogeneity. So I think that the opinion is that it's maybe not useful to kind of think of it in a dichotomous fashion of large versus small, and it must be one or the other that's the problem. But I do think that delineating it in this way is useful in some respects, because it makes us be more specific, and at least doing that can provide more specific targets for treatment. And the body of evidence about the peripheral airways in asthma is building, and we know that they're implicated in important aspects within asthma, so such as peripheral airway dysfunction is associated with airway hyperresponsiveness, which is an outcome that we don't want in asthma. It means that the airways are more predisposed to bronchoconstrict. We know that peripheral airways are correlated with asthma control, and that peripheral airway dysfunction can predict response to inhaled corticosteroid titration. So those are some things that we know. But the link with peripheral airway function and exacerbation risk was unknown. So that led me to the first kind of investigational part of my PhD. So exacerbation of asthma is an acute episode of worsened symptoms responsible for lots of healthcare resource use, morbidity, mortality, and really there's poor understanding of why some patients experience recurrent exacerbations. We know that asthma as an umbrella term is perhaps unuseful, and improved phenotyping of asthma patients is highlighted as a priority. And of particular importance is identification of characteristics specific to those who do exacerbate. And I think identifying these characteristics would help us understand physiological mechanisms behind exacerbation of asthma, as well as identify clinical markers of exacerbation risk, which could be helpful for personalised medicine. So the aim, therefore, was to assess difference in small airways function in subjects with asthma who exacerbate and compare it to those who do not. So what we did then was we had cross-sectional assessment of airway function for a cohort of asthma subjects, and they were differentiated according to their exacerbation history. So the stable group were those that had not had an exacerbation for 12 months, they'd been stable. The exacerbation prone group had had at least one exacerbation within 12 months, but had been stable for at least 4 weeks. And the final group were the treated exacerbation. So they'd had an exacerbation within 4 weeks. And this is a group of patients that are understudied really, because often a recent exacerbation or chest infection is an exclusion criteria when we're assessing airway physiology. And the test that we looked at, as well as the traditional spirometry, was the multiple breath nitrogen washout, so measures of ventilation heterogeneity in the conductive and asthma region, and also respiratory mechanics from oscillometry, so respiratory system reactance and resistance. So this plot of box and whisker diagrams displays all the parameters that were statistically different between the stable and exacerbation prone group. So we have the FEV1 reported as its Z-score was worse in the exacerbation prone group. Also, the exacerbation prone group had kind of more negative respiratory system reactants, so stiffer lungs. I just want to highlight these two in particular. So their ventilation heterogeneity in the asthma region was worse in the exacerbation prone group. They also had a worse delta XRS, which is the difference in inspiratory and expiratory reactants and is a marker of dynamic airway collapse. So that was worse between these groups. So what's interesting is that the treated exacerbation group actually looked very similar to the stable group. So that suggests that what the intervention at point of exacerbation, so high dose oral corticosteroids, etc., is kind of reversing this abnormality that we see in the exacerbation prone group, and is potentially a parameter that we can look to target with treatment in an attempt to try and avoid exacerbations for the exacerbation prone group. Okay, so the outcome of that then was that, okay, the peripheral airways and peripheral airway dysfunction seems to be a clinically important parameter, but how can we target these airways with therapies? So when we're thinking about inhaled therapies, they're topical treatments and they need to be applied directly to the site that they're treating. They're very different. Obviously, it's easy if you're applying a cream. It's a little bit more difficult if you're wanting to apply a topical treatment to the airway. You have to make the right angle and then let it deposit. So there's various things that affect delivery of drug to airways. So one is lung volume, the lung volume at which you start inhalation of the drug, how much you inhale, the speed at which you inhale, so higher flow will increase kind of deposition at the back of the throat, which we don't want, because then the drug will just end up in the stomach by the esophagus. How long you complete a breath hold for will affect how much time there is for Brownian diffusion of particles to deposit. And the other big one is particle size. So we know that particle size also is a factor of where drugs deposit. It's a little bit of a kind of Goldilocks scenario, because if it's too big, again, it's just going to deposit at the back of the throat. But if it's too small, actually, it'll just go in and come straight back out again. It won't have the mass to deposit. So fine particle aerosols that in theory reach the lung periphery are marketed by pharmaceutical companies. However, there's no consensus or guidance on what inhaled therapies are best in terms of particle size. And I think that's in part why the literature is conflicting and confusing, is that insensitive tests have been used, one, to look at response. So if you're looking at response with spirometry, it's probably not going to be sensitive to look at changes in the periphery, or that patients just haven't been categorized appropriately. So like if asthma is an umbrella term and everyone's been lumped in together, then maybe it's not surprising that overall we don't get a better response on one particle versus another, and we should be looking differentiating these patients a little better. So that led me on then to do some particle sizing experiments. So it's been shown with gamma scintigraphy that particle sizes of 2.6 and 5.5 micrometers, and that's median mass aerodynamic diameter, deposit preferentially in the small and large airways. So that was the aim, to achieve particle size distributions with those MMADs. So I went off to Sydney and used the laser diffraction device called a spray tech. And I was just investigating there with nebulizers that you can kind of, that are available to buy for anyone. So they're jet nebulizers, and how a jet nebulizer works is there's a compressor attached and it forces the gas through the solution and produces an aerosol that way. And there's various ways you can alter the particle size distribution by altering the flow, by attaching spacers to catch the large droplets, etc. So I did a great series of experiments doing that. And these were the outputs here of the kind of best case scenario I could achieve. And unfortunately, there's just too much overlay of those particle size distributions. So unfortunately, after all that time, I hadn't come up with an answer. That led me a little bit further down the trail. And I ended up talking to Sir Jim Fink in Aerogen in the States. And he actually supplied me with some vibrating mesh nebulizers, one kind of standard, which was able to produce a large particle MMAD of 6.2, and the vibrating mesh nebulizers, I guess, are a little bit more sophisticated technology. They have kind of plates that vibrate and force the solution through tiny holes, and that is what creates the aerosol. And they tend to have a narrower particle size distribution, which was suitable for my needs. And the device that actually produces the small particle aerosol is called a PDAP, so a fine particle aperture plate, photo-defined aperture plate, which was actually developed to deliver surfactant to premature babies. So once I'd kind of worked out how I was going to target airways with the drug that I was going to do in the experiments, then I started to think about how I was going to complete the spatial assessments to complement the physiological tests I was doing. And I needed to do this without any fancy gases. That's kind of outside of the scope of what I could do. And as we know, MRI of the lungs is technically challenging. It's great if you're using hyperpolarized gases, but as I say, outside the scope of what I wanted to do. So imaging with oxygen or oxygen enhanced MRI has been used in the assessment of ventilation. And that's because oxygen dissolved in the lung tissue and pulmonary venous blood shortens the T1 longitudinal relaxation time. That refers to the relaxation of protons as they realign with the external magnetic field, measured at inversion time, TI. And we can use oxygen in a technique called specific ventilation imaging. And this technique uses oxygen as a contrast agent during a gas wash-in. So it's kind of just like a multiple breath nitrogen washout, as I explained before, but it gives us more information in that it provides spatial information of ventilation heterogeneity. So how we perform this test in the scanner, maybe I should start by saying specific ventilation simply is the ratio of fresh gas supplied to a lung unit relative to the baseline volume of gas. And how we measure this in the SVI MR technique is we get the subject in the scanner and we do 220 images, and we train them at the beginning to be at the point of FRC, so the end of a breath out at each image acquisition. And I'll do a block on air and then a block on oxygen. And we look at the rate of signal change, which is reflective of the alveolar partial pressure change of oxygen. And it's from this that we can work out specific ventilation. So really, it's not about, and I have to quote Kim Prisk here, but it's really not about how bright it gets. We're not interested in where the signal intensity gets to, and that's great because it accounts for lots of confounding factors. It's about how fast that signal is changing. So I've just got an example here. This is an example SVI map on the right. This was taken at 1.5T. So Tesla. Yes, because SVI, the published technique of SVI has previously been formed on scanners of magnet strength 1.5. And what we can see here is, so this is a single sagittal slice of right lung. And we can see that the hotter colours are greater SV, and the SV is greater in the dependent region of the lung. And we would expect that because the lung is kind of susceptible to the effects of gravity. And if you think of, it's like the slinky effect. So the lung units in the dependent region of the lung are not as expanded as the non-dependent regions or units. So the more expanded regions at the non-dependent region receive less fresh gas relative to their baseline volume and have therefore a lower specific ventilation. So that's been shown. And also we can see spatially recurring ventilation defects on SVI, and that's when subjects are challenged with agents such as histamine or methacholine to induce ventilation defects. So that is SVI on 1.5T. I wanted to use a 3T scanner at MBI, so that meant that we had to develop a 3T protocol. So we know that MR imaging of the lung at higher field strength is prone to susceptibility artifacts as well as noise from blood flow, and that affects our SNR. So what we set out to do was first of all complete a titration study to work out the optimal TI in terms of contrast ratio and signal to noise ratio. And after that, what we had to do, because of the unwanted vascular signal that appears at 3T that isn't there at 1.5, is we implemented cardiac gating so that the image acquisition not only was respiratory gated by the subject, but also it would occur during diastole. So at the kind of relaxation phase during the cardiac cycle to minimize the amount of blood flow. We also implemented extra post-processing steps in the form of a median filter, and that was to try and remove spikes from kind of poorly cardiac gated images in the run. So then I've got a couple of examples here of the SVI map. So these is just on one kind of healthy subject at 1.5 and 3T. You can see that the 3T one is much noisier, but we still get the kind of higher SV values in the dependent region. So I decided to do like a comprehensive gravitational assessment of these data. To do this, I took the sagittal slice, removed the peripheral layer as that perhaps contained incomplete voxels. With the remaining region of interest, I sliced this into isogravitational slices and then plotted the average SV value for each slice from posterior to anterior, so posterior being the dependent lung. So if I just talk through subject 2 first, can see that, I mean, the SV values are comparable. If we look at these, they're between 0.2 and 0.3, and then for this subject, they're closer over to the 0.1, 0.1.5. So the values are comparable, but what we're really looking at here is the gravitational relationship that we expect to see. And there it is on the 1.5T running green. And although the data is noisier at 3T, we still maintain that relationship. For subject 1, we see the relationship at 1.5T, but at 3T the relationship's lost, and I think that's because they're taller, so they inherently have larger lungs, and they also therefore inherently have lower SV, because if you have larger lungs, your baseline or like resting lung volume is larger, and the ratio of fresh gas being delivered is less. And because we're trying to measure lower values of SV and 3T is noisier, we're just losing that sensitivity over here. So the other MR technique that I've used is, just checking my time, Peripheral. So Peripheral is phase resolved functional lung imaging. And this was first kind of described back in 2006 by Zapke and colleagues, and they simply created a phantom lung and then measured like MR signal at various levels of compression and expansion, and realized that that was a linear relationship, and that is the concept of Peripheral. It's measuring signal intensity and using that to well, assuming that reflects kind of inflation or deflation, and then working out regional ventilation from that. The great thing about Peripheral is that it is so easy. There are no contrast agents, not even oxygen. There's no respiratory gating. The subject, just the only instruction is just relax and breathe normally. And then there are 250 really quick images taken. And then these are registered volumetrically to a point within the respiratory cycle. So they're all registered to a point midway between end expiration and inspiration. And then it's the signal intensity changes in the ventilation frequency domain that is used to determine the regional ventilation. So here is kind of just an ROI of that mid respiratory cycle volume, and then on the right a ventilation map there displaying ventilation throughout the MRI. And again, this is a single coronal slice. So that was kind of where I was at with the methods I was going to use, including the spatial assessments. So then I started the kind of prospective part of my project and recruitment, and I recruited patients with asthma from the Alfred clinic. They were non-smokers with less than 10 pack years. They had no comorbid respiratory or cardiac disease, known responsiveness to salbutamol, and they withheld their bronchodilator therapy. And these very obliging subjects came and completed an extensive testing session with me. So they did physiological testing at baseline and some imaging. Well, they did Peripheral and SVI, but I'm just going to talk about Peripheral today. Then they had their bronchodilator and then repeated post-bronchodilator testing. And they came for 2 visits, so 1 small particle and 1 large particle visit in a random order. So these are the kind of demographics and baseline characteristics for the cohort. So I've been doing this research over the past few years, which involves an aerosol generating procedure in the time of a global pandemic, so it hasn't been easy. So the original aim pre-pandemic was to get quite a few more, but I managed to recruit 10 and test 10 in total. The cohort overall displayed peripheral airway dysfunction because their SSIN, so ventilation heterogeneity in the asthma region was above the upper limit of normal. However, their ventilation heterogeneity in the conductive region was below the upper limit of normal, so within normal limits. And for those that responded to either small or large particle, they displayed a greater reduction in their peripheral ventilation heterogeneity and improvement in their spirometric FEV1 with a small particle SABA. And there was no significant difference for their response in the conductive region. So I can't quite see my VDPs there, but I just thought I would show a pre and post example from the Peripheral ventilation map. So at baseline, you can see that there are more dark regions and some very dark regions, showing ventilation defect. And I think at baseline for this subject, it was 42%. And then post-bronchodilator, you can see a lot of the dark regions have turned light. And this, there's still some defect here, but the area of defect is reduced and the overall VDP came out at 22%. So that's all making sense. When I looked at the cohort altogether, it's not always acting as we would expect. So this is just all visits together, and then I've separated the VDP response, so VDP measured at baseline, and then post-bronchodilator for large particle and small particle. And what you'd expect, I think, is at the very least for the VDP to stay the same or reduce, hopefully. But on some occasions, we're getting an increase in VDP. And I don't know why that is yet. I think that a lot of the data coming out about Peripheral, and you know, it is great and it's correlated with clinically important markers, particularly in transplant cohorts. I think that's been done on 1.5T. Also, my data is limited in that it is just one slice, but it is the same slice pre and post. I'm not sure why sometimes it's measuring an increase in VDP, and I need to think more about kind of the calculation of this and what it really means. I thought I'd just say a little bit on, so just another couple of examples of Peripheral ventilation maps for subjects at baseline and post-bronchodilator. And I've picked two that have responded well on Peripheral and also responded well on physiology tests. But their responses on Peripheral are quite different. So this person has kind of reduced ventilation at baseline and quite a heterogeneous improvement post-bronchodilator, which looks lovely. And then this person, whilst it's improved, they still have these areas of defect. And I think that it's showing kind of the benefits of completing tests like this and having this, allowing the spatial assessment. It's just achieving things that we can't do with lung function. And I think that it's quite an exciting technique, although there's things to overcome and further work to do on the calculations. The fact that it's so easy to do, there's no contrast or ionizing radiation, you can do lots of serial measurements. It might be good in the future for targeting therapy, such as you know, like bronchothermoplasty, when we're like really looking at being more targeted with that therapy. So overall, these are just preliminary results, but they have demonstrated a greater improvement in peripheral airway function post small particle SABA, so bronchodilator. And these results are supportive of the findings of Burbank, who showed a greater improvement in airway function following a switch to fine particle inhaled corticosteroid for those that also had high ventilation heterogeneity in the Asthma region. I think it shows that aerosol particle size is an important determinant of bronchodilator response, and these findings are supportive of using more sensitive tests of airway function to aid in asthma characterization and could lead to a more individualized approach when managing asthma patients. And in a hope really to achieve the ERS goal of asthma in remission. And I have lots of acknowledgements here. I'd like to particularly point out Richard and Louise at MBI have been so helpful and supportive and managed to help me get through those 10 patients at a really difficult time with research closes, etc. And that's it.
Thank you, Claire, for a lovely talk. We do have a question from Michael Abramson. You can allow Michael to talk if you'd like to ask it in person. Michael? Oh. That's not working. Sorry, Michael, that was coming through my speakers as a mess. I don't know if anyone else's. I might ask a question then. How many patients were in your original cross-sectional analysis with stable exacerbation prone and treated exacerbations?
Yeah, they were quite small groups. So I think it was 9, 10 and 12. So yeah, around 10 for each group, which again is small, but I think that that is one of the things that has limited some of the kind of conclusions that can be drawn from, say, large clinical trials that have, you know, hundreds of patients recruited. They don't use these very time-consuming tests. So I think it's positive that we've been able to show differences between the groups with such small numbers.
Michael has a follow-up one. Were some of those who have been treated still on oral steroids or anything?
Sorry, in which group?
I assume on the either group.
Yeah, so for the part when we're looking at the exacerbation groups, I could go back. Oh, no, I can't. They were all GINA kind of 4 or 5, so they were all kind of severe asthma cohort on. Yeah, a lot of them were already on like maintenance oral corticosteroids.
Okay, thanks. Paris has asked a question. Thank you for a great talk. Is it possible to image at the time of inhalation of a drug, i.e. at the time of bronchodilator administration? Wondering whether ongoing ventilation heterogeneity is due to drug not accessing certain areas of the lung.
Good point. Yes. I know that well, to image where a drug is deposited, there have been studies where they've like radio labeled the drug to enable to see exactly where the drug has deposited. That was outside of the scope of what I was doing, and I had to just base it on like published literature and using the same particle size distributions. And I think that, and whilst yes, you don't actually know where the particles are necessarily exactly depositing, and if they have heterogeneous ventilation anyway, then that is going to affect that. But the fact that with the small particle, they've responded in their periphery, and with the large particle, they haven't, I think we can assume that I have been able to target the periphery with the small particle.
I guess I have a slight follow-up question to that one. Did you do any analysis, I don't know how possible it is, around like drawing ROIs around the periphery versus the internal regions of the lung to see if there was major difference, if there was any difference between the particle sizes?
Not yet. Not yet, no. But that is a good idea and something that I've been thinking about. It would require kind of writing that software to kind of segment the lungs into you know, periphery and central. So that's kind of like next step.
Okay, thanks for that. I did notice on your initial testing that the 3T was noisier, but the signal did look a little higher, the signal intensity, or at least the signal range. Mm-hmm. Do you think if you could sort out some of the 3T's issues that it would be a better modality, or what do you think between 1.5 and the 3? Do you think it would be possible?
Yeah, personally, I think we have exhausted kind of what we can do with 3T in terms of sorting out that signal and ensuring that it is the ventilation and the signal intensity changing due to oxygen delivery. I think that honestly it's better at 1.5. There's just less technical things to get around. Because if you think about the vascular signal that we're trying to avoid in a ventilation scan, whilst you can cardiac gate, there's only so much you can do with a scanner, and the heart rate is variable. So you can set that at the beginning when the heart rate is whatever it is, and as that changes, it just means that you're going to mistime some image acquisitions, and there will be vascular signal that either is removed at the post-processing part or prior to that, just because it's so affected by the signal. But I don't think that it's better. But I think that, you know, we've managed to produce a protocol that produces feasible results. And I think that as long as you are comparing like apples with apples, so you couldn't compare like a 1.5T scan with a 3T scan, but looking at pre and post salbutamol, for instance, if you're using the same protocol or same magnet strength, then that's okay.
Right. I don't see any more questions. I think if there's no more questions, it really just remains to thank Claire for a wonderful talk. Very interesting stuff, as Michael said. Some really nice MR pictures without hyperpolarized helium. We would add the hyperpolarizer at MBI should hopefully be up and running soon with the new laser. Claire was meant to be doing a bit of that. The really, it is a lovely piece of work, and there's so much going on with lungs with X-rays now, Claire, that, you know, that having an ability to repeatedly scan people with an MR is going to be really critical. You just can't keep delivering dose via X-ray, all the new trendy X-ray techniques, but yeah, we'll see where it all goes in the future. So thank you for a lovely talk. The next talk in our next scheduled seminar is radiopharmaceutical evaluation of novel bifunctional chelators and bioconjugates for tumor imaging and therapy, so a PET study, presented by Nanja Kubil from the Institute of Radiopharmaceutical Cancer Research at the Helmholtz in Dresden. So please stay for that one, which will be in a month's time. We're looking forward to that. And thank you, Claire, for a lovely talk. No one's got any more questions?
Thank
Thanks,
you.
Claire.